Imagine a patient with asthma. They are struggling to breathe. The airways are tight. Air cannot move freely. Now imagine this. Instead of sending the drug through the whole body, we send the medicine directly into the lungs. Within seconds, the drug reaches the airway. Relief begins. This is the power of inhalation drug delivery. Today, we will clearly understand how respiratory drugs are delivered to the lungs. We will explore inhalers, spacer devices, nebulizers, and even peak flow monitoring. Nothing skipped. Everything explained clearly. First, let us understand the inhalation route. Inhalation means delivering a drug directly into the respiratory tract through breathing. Instead of swallowing a tablet, the medicine is breathed into the lungs. This method is extremely useful for diseases such as asthma, chronic obstructive pulmonary disease, COPD, and other airway diseases. Because the drug is delivered directly to the airways, several advantages occur. The dose required is much smaller compared with oral medicines. Why? Because the drug does not need to travel through the stomach, through the bloodstream, and then finally reach the lungs. Instead, it acts exactly where it is needed. Another important advantage is rapid onset of action. Relief can occur within minutes. Also, because the drug mostly stays in the lungs, systemic side effects are reduced. So inhalation therapy provides rapid action, direct effect on the lungs, lower drug dose, and fewer systemic adverse effects. Now let us look at the types of inhaler devices. Several inhaler devices are used to deliver respiratory medicines. The most common types include pressurized metered dose inhalers, called PMDI, breath-actuated inhalers, and dry powder inhalers, often called DPI. Many patients can learn to use a pressurized metered dose inhaler effectively. However, some patients find these devices difficult. This problem is especially common in elderly patients and children. The difficulty occurs because PMDIs require coordination. The patient must press the inhaler and inhale at exactly the same moment. If the timing is wrong, the drug may hit the throat instead of entering the lungs. This reduces treatment effectiveness. To solve this problem, we use spacer devices. A spacer is an attachment placed between the inhaler and the patient's mouth. It acts like a holding chamber for the aerosol medication. Spacer devices provide several important benefits. First, they remove the need for perfect coordination between pressing the inhaler and inhaling. Second, they reduce the speed of the aerosol particles. This helps prevent the drug from crashing into the throat. Third, spacers reduce drug deposition in the oropharynx, the mouth and throat. Fourth, they allow more time for the propellant to evaporate. And finally, spacers increase the amount of medicine reaching the lungs. Because of these advantages, spacers are especially helpful for certain patients. For example, patients with poor inhalation technique, children, patients receiving high-dose inhaled corticosteroids, patients with nocturnal asthma, and patients who frequently develop oral candidiasis, a fungal infection in the mouth caused by inhaled corticosteroids. Now let us discuss choosing an inhaler device. When selecting an inhaler, the patient's preference should always be considered. There is no strong evidence that one device must always be tried first. In adults with stable asthma, studies show that a pressurized metered dose inhaler with or without a spacer is just as effective as other handheld inhalers. However, some patients prefer dry powder inhalers because they are easier to use. Now, an important rule about corticosteroids. When patients receive high doses of inhaled corticosteroids, a spacer should always be used. Why? Because spacers reduce local side effects, especially oral candidiasis. Next, let us discuss acute asthma treatment. In mild or moderate acute asthma attacks, treatment can be given using a pressurized metered dose inhaler with a spacer. Interestingly, this method is at least as effective as nebulization in many cases. Sometimes patients are switched from a PMDI to a dry powder inhaler. When this happens, patients may notice something unusual. They may feel less sensation in the mouth or throat during inhalation. They may also experience some coughing. This is normal. It does not mean the drug delivery is reduced. One of the most important factors in inhalation therapy is correct inhaler technique. Patients must receive careful instruction on how to use their inhaler. If the technique is incorrect, the medicine may not reach the lungs. This can lead to poor drug delivery. Doctors may mistakenly think the treatment is not working. Therefore, inhaler technique should be checked regularly. Another practical issue is inhaler confusion. Some patients receive multiple inhalers that look different. This can lead to mistakes. To avoid confusion, healthcare providers should minimize the number and types of inhalers prescribed. Prescriptions should clearly specify the brand and device type. This ensures patients use inhalers they have already been trained to use. Safety is also important. The MHRA has reported cases where patients accidentally inhaled loose objects trapped in inhaler mouthpieces. This can cause airway obstruction, which can be dangerous. Therefore, patients should always follow these safety steps. Before using the inhaler, remove the mouthpiece cover completely. Shake the inhaler. Check the inside and outside of the mouthpiece. Make sure the device is clean and undamaged. And after use, store the inhaler with the mouthpiece cover on. Now let us discuss spacer device care. When using a spacer, the patient should inhale immediately after pressing the inhaler. This is because the aerosol medication inside the spacer is short-lived. Usually, single-dose actuation is recommended. Patients can inhale the drug in two ways. Either take one deep breath or use tidal breathing, several normal breaths. Both methods are effective. Spacer devices must also be cleaned regularly. Cleaning should be done once every month. The method is simple. Wash the spacer using mild detergent. Do not rinse after washing. Allow the spacer to air dry. Why should it not be rinsed? Because rinsing can increase electrostatic charge inside the spacer, which can reduce drug delivery. Before each use, the mouthpiece should be wiped clean. Spacer devices should also be replaced every 6 to 12 months. Now let us move to nebulizers. A nebulizer is a device that converts a liquid drug solution into an aerosol mist. The patient then inhales the mist through a mask or mouthpiece. Nebulizers allow delivery of larger doses of medication to the airways compared with inhalers. Nebulizers are used in several situations. They are commonly used to deliver beta-2 agonists or ipratropium bromide during acute asthma or COPD exacerbations. They may also deliver beta-2 agonists, corticosteroids, or ipratropium bromide regularly in severe asthma when inhalers cannot be used. In cystic fibrosis, nebulizers can deliver antibiotics such as cholistomethate sodium. They may also deliver mucolytics to help clear mucus. In children with severe croup, drugs such as budesonide or adrenaline may be nebulized. Another example is pentamidine isethionate, used for prevention and treatment of pneumocystis pneumonia. In severe or life-threatening asthma, nebulized medicines are usually given over 5 to 10 minutes. Nebulizers are commonly driven by oxygen. This is important because beta-2 agonists can worsen arterial hypoxemia. Using oxygen during nebulization helps prevent this. However, treatment should never be delayed if oxygen is not immediately available. Before prescribing a home nebulizer, a trial period should be performed, usually 2 weeks using standard treatment, then 2 weeks using nebulized treatment. If the nebulizer is prescribed, patients must receive clear instructions on use, cleaning, and maintenance. They should also perform peak flow monitoring. And importantly, during acute attacks, they should seek medical help instead of relying only on self-treatment. Follow-up should occur after 1 month and then annually. Not all the drug from a nebulizer reaches the lungs. The amount depends on several factors. These include the type of nebulizer, droplet size, breathing pattern, and the patient's lung condition. Even in ideal conditions, the maximum drug reaching the lungs is about 30%. Often it is around 10% or less. The remaining drug stays inside the device or deposits in the tubing or mouthpiece. Particle size also affects drug deposition. For airway diseases like asthma, the ideal particle size is 1 to 5 microns. For alveolar deposition, such as with pentamidine, particles should be 1 to 2 microns. There are several types of nebulizers. The most common are jet nebulizers. These require a gas flow of 6 to 8 liters per minute. They can be driven by air or oxygen. In acute asthma, oxygen is preferred. For home use, patients usually need an electrical compressor because oxygen cylinders are not practical. Another type is the ultrasonic nebulizer. These devices use ultrasonic vibrations to create aerosol particles. They do not require gas flow. However, they are not suitable for certain drugs, including Dornase alpha and some nebulized suspensions. A newer type is the vibrating mesh nebulizer. These devices push liquid medication through a tiny vibrating mesh with microscopic holes. They produce uniform small particles. They are silent, portable, battery-operated, and do not require compressed air. Some nebulizer drugs require dilution. The usual diluent used is sterile sodium chloride, 0.9%, also called physiological saline. Sometimes inhalation therapy is not possible. In these situations, oral drug delivery may be used. However, oral drugs cause more systemic side effects. Examples of oral asthma medicines include corticosteroids, theophylline, and leukotriene receptor antagonists. In severe acute or life-threatening asthma, drugs may be given by injection. This is called parenteral drug delivery. Examples include beta-2 agonists, corticosteroids, and aminophylline. If treatment begins in the community setting, the patient must be urgently transferred to hospital. Finally, let us discuss peak flow meters. A peak flow meter measures the maximum expiratory flow rate. In other words, it measures how fast a person can blow air out of the lungs. Peak flow monitoring can help patients who are poor at noticing worsening asthma symptoms. It is especially useful in severe asthma. However, studies show that adding peak flow monitoring to symptom monitoring does not always improve asthma control. Patients using peak flow meters must receive clear instructions. They should know exactly what to do if their peak flow falls below a certain level. This is usually part of a written asthma action plan. Patients may be allowed to adjust some medications within predefined limits. Peak flow charts may also be provided to track lung function over time. That is the full picture of respiratory drug delivery, from inhalers to spacers to nebulizers and peak flow monitoring. Understanding these methods is essential because correct drug delivery can determine whether a patient breathes easily or struggles for air. In the next video, we will explore airways diseases, especially obstructive conditions like asthma and COPD. So if you want to master BNF Chapter 3, make sure to subscribe and turn on notifications. See you in the next lesson.